This podcast is brought to you by North Carolina's electric cooperatives.
This is NC Spin, an unrehearsed discussion on issues of interest to North Carolinians. Now, here is your moderator, Tom Campbell.
Welcome to this special edition of NC Spin. The topic this week is health care, and we're pleased to be at the winter meeting of the North Carolina Academy of Family Physicians in Asheville. We've assembled an impressive panel of healthcare professionals, so let me introduce them to you. Beginning with Dr. Mandy Cohen, who's the former Chief Operating Officer of the Center for Medicaid and Medicare Services in Washington, currently our Secretary of the North Carolina Department of Health and Human Services. Dr. Mark Stacy is the former Vice Dean for Clinical Research at Duke University, currently 93 days worth, I understand, is the Dean of the Brody School of Medicine and Vice Chancellor for Medical Affairs at East Carolina University. Representative Greg Murphy is a practicing urologist and representative in the North Carolina House, where he's chair of the Health and Human Services Appropriations Committee, and I might add he is also the primary legislative sponsor of the STOP Act, which I'm sure we'll talk about later on. Dr. Shannon Dowler is the former president of the North Carolina Academy of Family Physicians and joins the panel as a practicing physician who's practiced in Western North Carolina for 18 years and currently works as the Associate Chief Quality Officer for Mission Health. Dr. Mary Hall is the Senior Vice President of Medical Education and Chief Academic Officer at Carolina's Healthcare Center in Charlotte, and a professor of family medicine at both CHS and UNC in Chapel Hill. Welcome to all of you. Every era has its key issue. Without question, the key issue in this era is health care. And we want to discuss some of the leading health care issues facing our state right now. Beginning with how healthy is North Carolina? The data shows that Americans spend some $10,000 per person per year for health care. And yet, compared with 11 other major industrialized nations, we rank last in quality and 26th in the world in life expectancy. Greg Murphy, how can that be? Our country is the most innovative. We've got the best technologies, the best drugs. Why are our health care outcomes not the best?
Well, Tom, I believe it has to do a lot with probably three key points. First is patient expectations. We have to look as patients and see what are our expectations of healthcare. What are we expecting? What are our lifestyle, tobacco, weight? Those are other issues. What do we expect at end-of-life care? Palliative care considerations need to be something that really becomes the forefront in our country, unlike that are in other industrialized nations. I think we as physicians also need to set a bit of different expectations. When do we treat? When is it appropriate to treat? When do we withhold treatment? We also have to look at our liability issues. We practice so much defensive medicine. Look at our radiology reports, how many times we order another test. We also have to look at every new bell and whistle that we as physicians. I have to say, as a surgeon, a lot of my fellow colleagues also use every new bell and whistle. We have to look also at where we are as industries. It's not wrong to make a profit, but the cost of medications, the cost of medical devices is unlike anywhere else in the world. And we have to actually look at our governmental structure. We are placed so much of a burden on how our daily practice is put forward compared to other countries. So much of our time is spent dealing with the business of medicine rather than the business of health, or rather the access to health care.
Shannon,
I think all these things will kill us.
Let me ask you, because Greg mentioned this business about North Carolina has high rankings so far as obesity, diabetes, high blood pressure. How much of the problem with our healthcare outcomes is because of our behaviors?
Well, without a doubt, a lot of our behaviors contribute to our healthcare outcomes. And you can take it in the extreme with the IV drug abuse problems we're having and people getting infected heart valves and requiring multiple valve replacements. That's a huge cost to the system. But even the basic things like childhood obesity, where oftentimes the kids and families don't have the food resources they need to eat healthy. And so there are a lot of things we need to do as a state to get upstream and start working on these things earlier.
Mark, Stacy, you are now in eastern North Carolina, having come from Durham. And in rural North Carolina, we know that poverty is particularly a problem among a lot of the people there. Is there a correlation between health outcomes and the standard of living of families?
Oh, certainly there is, and I'm delighted to be in Greenville, by the way, and hello to the students at Brody in the audience. I think that we have to really concentrate on real economic factors in terms of how we are providing health alternatives for our patients, particularly in eastern North Carolina. As we heard the Secretary speak in the previous lecture, unless we start trying to prevent healthcare problems, we are not going to be able to shift our expenditures to make us a healthier state.
Proactive rather than reactive.
Yes, sir.
Mary, the data shows that having a medical home, a relationship with a primary care physician, can help lower healthcare costs. An Oregon study said, for instance, every dollar invested in primary health care yielded a savings of $13 in other healthcare services like emergency department visits and hospitalization. How does that go about? I mean, why does that work that way?
Well, I love those stats because they're right. This country, our triangle is upside down compared to other countries. Regions of this country that have the right percentage of primary care physicians have higher quality outcomes at lower cost. And we make decisions that allow our patients to choose the healthier outcomes. We're doing a lot of work across the state and country to try to get more primary care doctors into the workforce.
Can we document whether or not Obamacare or the Affordable Care Act has actually moved the needle any so far as health care outcomes?
Well, Tom, it's a great question, and we absolutely can. We can look at data now across the board where we see if you have access to an insurance card, you are more likely to live longer and live healthier. And if you look at, unfortunately, comparing North Carolina to, say, Indiana, where our current vice president, when he was governor, expanded his Medicaid program to cover more people and allow them to have insurance access. Over the last 3 to 4 years that they've had that access, they've made major gains on some of those quality indicators like diabetes and blood pressure and obesity, and made a huge impact on their opioid crisis.
I'd like to just sort of go around the horn here and ask everybody, because it's pretty well understood that the Tax Reform Act, which the two houses of Congress have now got to get together and kind of compromise on, is doing away with the subsidies for the Affordable Care Act. So knowing that it needs work, knowing that it needs fixing, we're told that about some 400,000 North Carolinians are going to lose access to health care, or they're going to have rates which are substantially higher. So, Mary, let me start with you. What suggestions would you make about how to fix ACA?
Oh, that's great.
Softball.
I think it's essential that we allow everybody to have access to health insurance, to Dr. Cohen's point. And the thought that we would decrease that access, which some of the new tax law is suggesting, is horrifying. Because every day that we see a patient in our offices and have to help them make decisions, life-changing decisions, or just decisions about how to provide the basic amount of care to themselves, and they can't make that decision because they don't have the insurance coverage to make those choices, is horrendous.
Greg?
I think so much of our health care dollar now is spent in the most expensive point, and that's in our emergency departments. Unfortunately, as with many issues in the country now, everything is becoming so politically polarized. And this is why I have to give a shout out for physician advocacy. We're the ones who know how to best take care of patients, and we're the ones who know how to most cost effectively deliver it. And so therefore, we have to become a force that helps deal with this issue, not just politicians that are not aware with medicine.
Yes, so many of you may know, I spent a number of years in Washington working to make sure that 16 million Americans were able to get access to insurance coverage, which is what Obamacare or the Affordable Care Act did. So any step back from them, I think, as our panelist has said, is really the wrong direction. I think what I'd like to see next, and this, as folks get access to that care, is really to think about how are we spending our dollars, and can we spend it in the best way possible. And I'd love to talk, and I know we will further, about how we think about health broadly, and not just about in the four walls of a hospital or a clinic, but thinking about a whole person, their behavioral health needs, their physical health needs, and also what's going on with them in their community.
Mark, how would you fix ACA?
So I think like everybody else in the room and many people watching, I'm not sure what insurance means anymore. And I think we are in a point where we're trying to evolve to provide health care to people. In my previous world as a Parkinson's doctor, we found that physical therapy was very important to the health of Parkinson's patients. It's a very small population. We could write grants and we could get physical therapists in our clinic. Now as we sit trying to take care of patients with huge problems with diabetes, with obesity, and other health factors, physicians need to be able to put patients in front of those their patients in front of those care providers in those clinics. And until we begin to evolve organically, we're not going to be able to define this new system.
Dr. D, how would you do it?
Well, the American Academy of Family Physicians Congress voted this year that health care is a human right, and we have to get health care to everyone. Every county in North Carolina has a family doctor, and we're happy to see the patients of North Carolina, but they can't be afraid of coming to the doctor because they can't afford it.
We're going to take a short break, and when we come back, we're going to talk about Medicaid reform.
NC Spin will return after these messages.
Agriculture is the backbone of our state's economy. It's the heartbeat of our rural communities. Its strength means bustling sidewalks and open signs in store windows. And with smart investments in our future, like the Plant Sciences Initiative and modern updated research stations, agriculture will remain the cornerstone of our economy. Because when agriculture is strong, our economy is strong.
For more than 45 years, the North Carolina Retired Governmental Employees Association has advocated for local and state government retirees. Whether protecting retiree benefits or fighting for cost of living adjustments, more than 70,000 members count on us to be their voice. Government retirees work for us, and we stand for them. Learn more at ncrgea.com.
We now return to NC Spin.
With almost 1.6 million North Carolinians on Medicaid, our state spends some $13 billion, of which the taxpayers of North Carolina are contributing about $2 billion in this government-sponsored program. 1 in 5 North Carolinians receives Medicaid. Secretary Cohen, when you became secretary earlier this year, the legislature had passed a managed care model that will move us from the fee-for-service to per patient per month funding. Now, last week, you submitted an amendment to the waiver that we submitted to CMS as succinctly as you can, because it was, 101 pages long. As succinctly as you can, tell us what was in that amendment.
Sure. So as you mentioned, Tom, we're moving from a state-administered program to an insurance-administered program. And when we looked around the country for the best that was going on around the country and pick the best things that each state was doing to put them together to build on what's here in North Carolina, the infrastructure that's here, to create a system that can deliver the best health outcomes, create a sustainable, strong, efficient Medicaid program, as well as support providers through that transition. And so major components of that include bringing together your physical and your mental health needs together in one insurance card. Right now you have 2. As we move forward in the future, we want that to be one insurance card. We want to make sure there's really good focus on care coordination. We know healthcare is complex, and we know that folks need help navigating through that, and we need to pay for those kinds of important services. We also need to invest in the workforce here in North Carolina, make sure we have the doctors and the nurses and the other professionals to take care of our patients. And we're a rural state. We need to focus on things like telemedicine and other opportunities to make sure that we can get access to care no matter where you are. And then lastly, I want to mention that we did make sure that we are moving forward in a conversation with CMS to think about giving more folks access to insurance coverage through Medicaid.
Greg Murphy, you've been in the legislature for a while now, and you've been part of these discussions. So far as it goes, the legislature's goal was to eliminate some of the cost overruns we've seen in some recent years, although in the last few years they have not been as dramatic. Have these managed care models, in fact, contained cost in other states where they've been implemented?
Well, Tom, I think there's a little bit of debate about difference of opinions about that. My concern is that you take the Medicaid dollar and all of a sudden we're now going to lose 10 to 15% of that to pay a company to manage the care. We have a 93% penetration in our state for individuals, for physicians that accept Medicaid. And as the Secretary said earlier in her talk, we don't want to lose that. We want to keep physicians providing care for the Medicaid patients, but we cannot do it if there's too much administration or if we're not being paid well enough. So that is a big concern.
Yeah, Shannon, the managed care model is going to provide for insurance companies as well as provider organizations. Medicaid recipients are going to be required to choose one provider for their Medicaid. Are they going to know enough to know how to choose?
I think patients that already are in a medical home probably will want to stay with that medical home. And my understanding is the state's gone to great lengths to make sure that we don't disrupt medical homes. And I think we have to give our patients a lot more credit. A lot of them know exactly where they want to go, but they're unable to go to those places. So once we open the resource, make it more available, I think patients will land where they need to land.
Mark, Greg mentioned this from a provider's point of view. We're told as much as 40% of healthcare costs are from backroom expenses and having to push paper and file claims and so forth like that. Is this new managed care model going to make the paperwork burden more intense than it is for care providers?
It's certainly going to change it some, and that's going to make it appear more intense for a while. I think there's a lot of understanding that has to come through from both a patient and physician perspective. And as a physician, I can tell you that many times I've felt frustrated that I couldn't answer the simplest questions about my patients about how they could get resources. And so we'll have to really concentrate on how to do that better.
Mary, whenever the subject of Medicaid arises, and the Secretary has talked about this, the Medicaid expansion in our state is also a topic that's talked out. Our legislature has so far refused to do so, although there is some effort, thanks to Greg Murphy and some others, to begin expanding the roles of Medicaid. Is there a mandate for expanding Medicaid in North Carolina?
Is there a mandate?
Yeah.
One thing I'd say is that as these conversations have gone on for the past couple of years, that I find that to be a very unifying principle among healthcare providers. The hospital, the doctors, everyone is in support of Medicaid expansion. So, I'm surprised when you find something that we're that unified about. It's got to be the right thing to do for the patients.
Yeah, and again, I know I sort of hit you cold with that question, but I think it is one that is a topic that's on many minds right now. Secretary, I can't conclude this discussion without talking about your recent efforts with Cardinal Innovations, one of the regional mental health agencies. You just recently took over the management of Cardinal. Tell us why you decided to do so and what benefits you hope are going to come from that.
Yeah, so earlier this week, we did assume the leadership of Cardinal Innovations as well as rescind the board structure, necessitating their board to be reconstituted. This was after a long pattern of noncompliance with the rules and regulations that the organization was bound to, relating to things like executive compensation, their severance packages, spending of the organization, but more. And it felt like we needed to take some steps to return the organization's focus.
Now, you
to
can't
the people
change
it serves.
those compensation packages that are contractually already written. Is that correct?
So there are rules around whether or not those executive compensation packages do comply with the law, and they do not. And so we, now that we are taking over at Cardinal, we're making sure that those compensation packages do comply with the law.
So there may be some clawback provisions here.
I think our lawyers are still working through that right now.
All right. Well, we're going to take a short break, and when we come back, we're going to be talking about the opioid crisis in North Carolina.
NC Spin will return after these messages.
Life's busy, but you are the master at managing it. Thanks to your know-how and some helpful tools. As a member of an electric cooperative, you have access to lots of innovative tools that help you better manage your home energy use and your budget so you can stay focused on what's most important. Discover how your electric cooperative can help you control your energy use at empowermenc.com.
You sleep on concrete till your body get immune to concrete.
My mom got my brother and I up and said, come on, we're leaving.
I became homeless in the beginning of this year.
When I was about 4 or 5 years old, our house caught fire.
I used to see my brother. If he see me, he'd turn and go the other direction.
We did the only thing that we could think of, and we went to a Salvation Army shelter.
You know, we don't have this, like, what's your background look like? We just say, what do you need?
I remember the man from the Salvation Army coming down with a box of clothes.
The Salvation Army officer bought my brother and I an ice cream cone.
Last week, my brother walked up to me, and he just started a conversation.
Today I've given my life to the Salvation Army because I remember what somebody did for me, my brother, and my mom over 30 years ago.
The Salvation Army for me means hope.
Compassion.
Family.
Support.
We now return to NC Spin.
Reports show that we have 3 people per day die from opioid overdoses, an increase of 25% since 2015. There are about 4 emergency room visits per day due to opioid overdoses. Shannon, Dowler, like the rest of the nation, we've got an opioid crisis. Now, there are a lot of people who want to blame physicians because they've been too liberal in prescribing pain management drugs. And certainly that's a factor. But there's some recent reports that indicate that overdoses from prescribed pills have been declining. Why is this problem still growing at such an alarming rate?
So there are 3 things I'd say about that. One, the pendulum has swung back and forth since I've been in medicine. In the 90s, when I went to medical school, I was being told that I had to measure pain as the 5th vital sign. And if I wasn't treating non-cancer pain completely, I was not a compassionate doctor. Then we started seeing drug-seeking behaviors, addiction escalating, and then the crossover into IV drug use and with the heroin use. And the new heroin's cheaper, it's more potent, and it's killing people a lot faster. And this has been a major contributor to physician burnout in our state and in our country. There's nothing more heartbreaking for a family doctor than hearing that one of their patients or the children or parent of the patient has died from an unintentional drug overdose. And it's also heartbreaking that a lot of these people are very young and they don't have access to health insurance. And they come into your office and they're ready to stop using their drug, but you have nowhere to send them.
Greg Murphy, you've been very active in talking about this particularly because you're saying that the use of naloxone, which has saved many lives in North Carolina, isn't enough. People aren't required to seek further treatment, such as substance abuse programs and so forth like that. Can the state actually mandate these programs?
No, I mean, that's something when our EMS folks go out and administer naloxone and they wake back up, that's nothing that can be forced upon them. And the sad thing is that even if it were, we don't have the facilities and we don't have the community-based programs to do it. And this is what I think is truly, if not anything, the biggest health problem that faces our state is our fact of we don't have the facilities, we don't have the funds for mental health services for those that have abused opioids or any substances.
Mark, the Secretary has spoken about the fact that many of these patients of opioid abuse don't have health insurance, which I guess just ties in with what we've been talking about with Medicaid and the Affordable Care Act and so forth like that. Does this bring us back to that Medicaid expansion issue?
I think it does, and I think that we have to recognize that addiction is an illness. There should be no stigma to that illness, and we need to be able to say to people, we want to help you and put a system around them, and without insurance for these patients, we won't be able to do that.
Mary, there's some evidence that the general public really is not fully aware of how severe the problem is and what some of the options are. What can we do to increase public awareness?
I think it's important that we speak frankly about this as an illness and that we help people understand the ways that they can receive that treatment. And I think you're absolutely right. In many conversations that I have, people are shocked to know that this crisis is what it is. And I think standardization of how we approach it helps the physicians, all the caretakers, the entire team, and the patient.
All right, we're going to take another break, and when we come back, we're going to talk about rural health care.
NC Spin will return after these messages.
NC Spin is brought to you in part by the North Carolina Farm Bureau. The Farm Bureau and Agriculture. We keep North Carolina growing.
The healthcare landscape is filled with questions and uncertainties of changes that are coming. In these times of change, there's one thing you can trust. You can trust your family physician to work for you, not only in treating sickness and disease, but also your overall health. Regardless of how healthcare might change, the men and women of the North Carolina Academy of Family Physicians pledge to work upholding your trust. Family physicians, your trusted healthcare advisors.
You sleep on concrete till your body get immune to concrete.
My mom got my brother and I up and said, come on, we're leaving.
I became homeless in the beginning of this year.
When I was about 4 or 5 years old, our house caught fire.
I used to see my brother. If he see me, he'd turn and go the other direction.
We did the only thing that we could think of, and we went to a Salvation Army shelter.
You know, we don't have this, like, what's your background look like? We just say, what do you need?
I remember the man from the Salvation Army coming down with a box of clothes.
The Salvation Army officer bought my brother and I an ice cream cone.
Last week, my brother walked up to me, and he just started a conversation.
Today I've given my life to the Salvation Army because I remember what somebody did for me, my brother, and my mom over 30 years ago.
The Salvation Army for me means hope.
Compassion.
Family.
Support.
We now return to NC Spin.
Accepted data indicates there's going to be a shortage of more than 30,000 primary care physicians by the year 2025, and this is especially going to affect the rural areas of our state. Mark, Stacy, the ECU Medical School turns out the second highest number of primary care physicians of any school in the nation. Tell us how you're able to encourage your students to go into primary care and family medicine.
Well, first of all, they're great students, and they have their heart into the mission of the Brody Medical School, and that is to provide care to rural areas in North Carolina. We plan to try to expand our class from the current 82 to 120 over the next 3 or 4 years, and Greg has been helpful enough in the legislature to try to get us a building to house those 120 students. And so our mission is to continue at our mission and to continue training people to be doctors.
Greg, are we doing enough to provide incentives for doctors to locate in rural areas?
I don't think we are. I think a lot of it also goes to Medicaid payments. Those folks are generally our poorer patients. And yes, hospital expansions have gone out and populated those areas with hospital employees, but no, we're not doing enough.
We hope you've enjoyed this special healthcare forum, and we appreciate our panel of experts for sharing them with us. And we thank the North Carolina Academy of Family Physicians for hosting us at their winter meeting. Next week, we hope you'll join us when we return to our regular program format of balanced debate for the Old North State. Until then, stay informed and watch out for the spin.